If we can all get settled and get started, we have a really excellent session planned for this morning and then for this afternoon, last day of the conference. And I'm very happy to be presenting a very quick update on our global health program. My name is Pallavi Pant, and I lead the global program here at HEI. Together with a very excellent group of people. So I think you've heard glimpses about this already from Bob and others over the last 2 days. But our global program builds on what we've been doing in the core research program, the air pollution and health program, for over 40 years to try and take some of that and see what we can do to help the work that's happening in other parts of the world and in places where data may not be as adequate and the needs may be different and the questions may be very different. And this program receives very generous support from philanthropies, from development agencies, and at any given time, the funding mix looks, very, very different. But we have a few pillars that we try to emphasize in all of the work we do, starting with ensuring that we are communicating about the health effects of air pollution, about impacts of air pollution on people's lives through a variety of means. So in addition to reports, we try to do a lot of events and workshops in different places. We try to produce more easily accessible materials like fact sheets and infographics, in some cases policy briefs, and we try to ensure that in all of the work we're doing, we center our partnerships with organizations and people who may be active in regions and know best what the questions are and how the answers can be relevant. And we'll hear a lot more about these partnerships and how such partnerships can continue to be built in places around the world through an excellent panel of experts we have coming up for the session. Some of you hopefully had the chance to see our poster on State of Global Air yesterday that was presented by Ada Wright. It has been a program that we've run for a few years now, started as a collaboration between us and the Global Burden of Disease Study that's led by the Institute for Health Metrics and Evaluation, and really built on the work that Aaron Cohen did for many years prior to me joining HEI, trying to get air pollution integrated into the GBD assessment. Finally, as again, I think on day one of the conference, we heard about the PAPA program, which was a major effort that HEI undertook several years ago, focusing on not just building new science and producing new evidence, but also ensuring that we have a cadre of investigators and scientists in country who are then able to lead the work for many, many years to come, even if HEI is not as actively involved in that location. But this work cannot be done just by a small group of people at HEI. There's many, many more involved, including our wonderful Global Health Oversight Committee, which has now been running for about 3 years. Some of the members of the committee are in the room, so if I can please request them to stand up so we can recognize them and acknowledge all the hard work and guidance they provide to our program, including Kiros, who's up here on the dais. In addition to the committee, we also have many, many collaborators, some in the room and some others who couldn't be with us during the conference, but we really acknowledge and we really value all the input we get. So as I go through some of the work we've been doing, if there are ideas that come into your mind or places where you think you would like to collaborate with us, please find me, please find my colleagues, because we would love to work with you and hear about what you think we should be focusing on. So State of Global Air remains a key part of the work we do within the global program. It focuses on communicating about the health impacts of air pollution, communicating about how air quality levels are changing in countries around the world, where we are beginning to see improvements or not. And I could go on and on about State of Global Air for maybe another hour, but just to give you a couple of highlights of what we've done in the last year. When we started, we were essentially aiming to produce annual reports that would give an assessment of where we are beginning to make progress, where there are still areas that require attention, and this was all at the national level. Last year, for the first time, we were able to produce a report in collaboration with Dr. Susan Annenberg at George Washington University and some of her collaborators, including Veronica Sutherland, who's here at the conference, to look at air quality and health impacts in cities and how those levels are changing. And it actually produced some very fascinating results that were taken up by people in many parts of the world, including the fact that if you begin to look at cities of concern, I know the map is really hard to read, but just look at the dark red spots that you can see. There's obviously South Asia and East Asia, which are always in the news, but there are also many cities in Western Africa, cities in Latin America, including Peru, where I know some of you have spent time over the last many years. And then also other parts of the world, like Central Asian cities, Tashkent, Danushbe, that are almost never in our attention in terms of places where we should be working on air pollution. We're hoping to continue some of this work in years to come. And we are now beginning to take an approach that we don't just want to produce these large global reports. We want to do work that is targeted at specific regions, relevant to the work that's happening there. And in response to that, last year, we also published a report on air pollution and health impacts in Africa and some work in Southeast Europe that I will talk about momentarily. In Southeast Europe, we've had a good program for about 2 years, and we are really hoping that we can continue some of this work over the next few years as the Ambient Air Quality Directive is finalized and discussed. And in this work, our goal was how do we bring the estimates and the data that we have available from GBD and bring them to bear together with the local health evidence that scientists have been producing in the region. So as part of this work, we brought together scientists and environmental groups and some policymakers as well to figure out what the most important questions are, organized a number of trainings in the region, and ensured that any materials we produced, like the report here, were also available in languages that are more accessible to people. So I'm assuming most of you will not be able to read the chart that's here. It's in Bulgarian, but it was very useful for people who are there and who are looking for data and information on air pollution in languages that they speak and work with every single day. And one event that I want to particularly highlight is a workshop we did in Plovdiv just before the conference, where we were able to get together with the policymakers from the region. In this picture here, we have then Environment Minister for Bulgaria, as well as local policymakers, environmental activists, physicians, researchers, to have a dialogue on what needs to happen. In the last several months, we have started taking action on, or sort of started engaging in East Africa as well. We were able to recruit a fantastic colleague, Victor Enthusi, who's also here at the conference. And we are hoping that we can figure out the best way for us to contribute in the region. We are starting in small steps. We just completed a workshop at the end of March, which was very well attended. Several of our committee members were there. We heard from a lot of people about the policy needs, the science needs in the region. And hopefully we will continue to find ways to work there, starting with some scoping review of health evidence in the region that we hope to undertake in the next few months. We've already produced a report which was at the African level, so maybe trying to do something that's more specific to Eastern African community, and finally building and expanding some of the networks that are beginning to form in the region to take work forward. Finally, in India, we have been supporting a research network for the last few years on air pollution and health that brings in people from the air quality community, from the public health community, and everything in between. And through this research network, we're supporting, again, trainings. Later in May, we are planning a consultation to take stock of the Indian evidence on health effects of air pollution with a view of informing the upcoming revisions to the Indian National Ambient Air Quality Standards. Our process is not as comprehensive in India. We don't do ISAs or other things, but we're hoping that some of this can begin to inform work that happens. And finally, we are very excited that we are in the very final stages of funding some research studies in India. So hopefully next year, I will be able to give you an update on where we are with that. But here's some of the highlights from the work we are doing. Very happy to add more during one of the coffee breaks. But now I would like to welcome Dr. Jennifer Peel and Dr. Kiros Berhane, both of whom serve on our review committee, have been working in the US and beyond for many, many years on topics related to air pollution and health, to take us forward through the session.
Thank you, Pallavi. Welcome. It's so nice to see everybody bright and early on our final day, so thank you for joining us. So my job is to really set up and frame the session today. So I wanted to spend a few moments trying to put this into context and set the stage for what we're going to hear in the next couple of sessions. So we are talking here about exploring the link between air pollution and health in high pollution environments, insights from recent research studies. We're going to hear a variety of talks today, really focused on this high pollution environment and some of the unique aspects, some of the unique questions, and some of the unique challenges that we can face in these high pollution environments. So in this context, I wanted to start by just talking about words. We all know that words matter. So when we think about high pollution environments, sometimes we tend to interchange some of the terminology like low and middle income countries and global north or global south, when we're really, perhaps it might be useful to be intentional about, what we're talking about. I'll point you to a very large body of literature. This is an example of one that nicely articulates the issue of what we're talking about, especially in global health contexts, and trying to be intentional about, how we're framing this issue, whether it really is a low and middle income country issue or whether we're talking about the environment itself or something else. And especially in global health, this is incredibly important to keep in mind because there's a lot of context and history for many of these categories. So many of the delineations that we're talking about here, whether we call these lower and middle income countries, LMICs, global north, global south, the lines generally fall along the same areas of the globe that you can see depicted here. And interestingly, we'll take a look at some pollution maps as well to see where we see some of these highest pollution environments, and they do often fall along the same general lines. But here, I do want to make sure we keep in mind that we are talking about high pollution environments, not necessarily always in line with what we mean by LMICs or Global South. So many of these contexts and the discussions that we have about high pollution environments are relevant in various contexts around the world, including in the US. We know that, and we'll start to point out that even in places like the US, Europe, Australia, we can have very localized high pollution environments as well. So putting this into context, taking a step back and thinking about what are we trying to imply by high pollution environments. So looking at for a second, just looking at the US, looking at the trends for annual fine particulate matter in the US in the last 20 years, we see a decreasing trend, and we can see that currently we stand at fairly low levels. Perhaps a success story in terms of what we're looking at for fine particulate matter. If we put this into a little bit of context, if we look at the WHO, the 2021 guideline is now set at 5 micrograms per cubic meter, changed from 10. We have the current US standard is, for the annual standard, is at 12 micrograms per cubic meter. The current EU is at 25. Hopefully this is not out of date. I'm not always keeping up with where that stands at this point. A proposed EU standard at 10. So all of these are fairly low pollution environments. Even if we look in the US, at the highest pollution environments, for example, for annual PM 2.5, looking at Bakersfield, California, we're still looking at levels that are fairly low in the global context. Thinking about where we're sitting now in Boston, very low levels, even with all the caveats with the purple air measurements, we are sitting here at very, very low pollution environments. Because of some of the trends, these recent trends over the last 20 years, HEI and others have recognized the importance of looking at environments at low levels of pollution. We had a lack of data. So there has been quite a bit of work looking at the low levels of pollution from HEI and others. Now there is increasing recognition that we can't forget about the high pollution environments either in this whole context. So if you look around the world and if you think back to where the lines were for when we talk about LMICs in the global south, we know that pollution is not distributed equally around the world. So if we look at these concentrations, even if you can't see the numbers, those highest levels at the darkest reds are annual averages in the range of 75 to 85 plus. When we're talking in the US and Europe and in Australia, with standards in the 10 micrograms per cubic meter range. So stark disparity in terms of what we're seeing in some of these environments around the world. So when we talk about the high pollution environments, you can see where those areas of the world are falling. Often what we mean is areas of sub-Saharan Africa, Asia, and Central and South America are where we're seeing the highest levels of pollution around the world. When we look at the trends, these trends are holding steady in terms of where we see these highest levels. Areas of South Asia, Sub-Saharan Africa, again, Southeast Asia are where we see these highest levels, and that trend has held steady over the last 10 to 20 years. We also see the disparities are increasing in many areas of the world as well. We see improvements in many areas of the world, but we also see that some areas that are at the highest pollution levels are still increasing. So hopefully this helps to put this into context in terms of what we're talking about with these high pollution environments as we hear our talks over the next hour or so. Also relevant to keep in mind that high pollution environments can happen anywhere, and we know this well in the US and other areas. Even when we live generally in low pollution environments, these high pollution environments can happen at any time. We see this with wildfires. We also see this on different temporal and geographic scales. We can see very high pollution environments even sited within our low pollution context. So with that, I will turn it over to our speakers, and I will go ahead and introduce our first speaker here. I'll note that Kalpana Balakrishna was our first speaker on the schedule. She's not able to join us today, unfortunately. So many of the points that she would make about concentration response functions and evidence in that gap, I think you'll hear from some of our other speakers as well. So we'll make sure we can focus on that. So it's my pleasure then to introduce our first speaker, Dr. Perry Hystad. Dr. Hystad is an associate professor in the College of Public Health and Human Sciences at Oregon State University, where he leads the Spatial Health Lab and is the director of the Environmental and Occupational Health Program. His research focuses on environmental exposure assessment and epidemiology with applications to air pollution, healthy built environments, and climate change. He has developed new methods to assess environmental exposure for large population-based health studies using novel technologies and geospatial data science approaches. He's an avid collaborator and believes that the most pressing environmental health problems must be addressed with interdisciplinary team science. Perry.
All right. Good morning, everyone. Let's see if I can get this to work. Okay, there's a little delay. So I'd first off like to start off with thanking and recognizing my collaborators. So there's a long list of people that contributed to what I'm going to present today. These are just some of them. I specifically want to call out Michael Brower, as well as Salim Yosef, who leads the prospective urban and rural epidemiological study. This is a picture of the PURE team. This is the last meeting we had in Istanbul in 2022, the first time we've been able to get together since COVID. These meetings happen every 2 to 3 years to bring together all of the investigators that are involved in the PURE team. So the PURE study was initiated by Salim Yosef at the Population Health Research Institute. This is in McMaster in Canada. PURE phase 1 enrolled 160,000 adults aged 35 to 70 from 800 urban and rural communities in 27 low, middle, and high-income countries. So this is really a massive undertaking that was initiated as a follow-up to the case control studies of interheart and interstroke. So really trying to look at the upstream drivers of a lot of the risk factors for cardiovascular disease. So when Salim started this back in 2004, so the pilot was done in Bangalore, India, they were really ahead of their time in terms of thinking about drivers of personal behaviors, exposures that influence cardiovascular disease. So comprehensive baseline data was collected. This included survey data on individual and household characteristics, community characteristics, a comprehensive medical history, blood collection, lung function. So the baseline data that was collected was really comprehensive for a study of this size. And then follow-up is conducted every 3 years to identify events. And so the initial goal of this study was really to fill the gap in high-quality health outcomes in low and middle-income countries and the risk factors for chronic disease. And so this was one of the first papers that was published. This is 5 years of follow-up data. This was really just a descriptive study, but it was published in the New England Journal of Medicine, highlighting really the importance of this data and the gap that existed in countries that don't have electronic medical records and good health outcome data. And so here, the green bar is incidence in high-income countries, light blue is middle-income countries, and then orange is low-income countries. And you see this gradient where cardiovascular disease incidence was greater in middle and low-income countries. And when you look at mortality, that disparity between high-income, low-income, and middle-income countries grows even starker. So at the same time, they looked at traditional cardiovascular risk factors. So this is the interheart risk score. This was calculated for each individual in PURE based on the survey data, including sort of the traditional risk factors for cardiovascular disease: age, sex, smoking status, diabetes, high blood pressure, the things that we typically think of and measure in epidemiological studies. And so there was a big disconnect between where the interheart risk score or the risk factors for cardiovascular disease were highest. So here we see that they're higher in high-income countries, and that gradient is going the other way. So we see larger cardiovascular disease incidence and death in low and middle-income countries, but lower risk factor scores. And so this was used to fund a large study in PURE looking at the impact of healthcare. So what does healthcare mean for prevention and treatment of chronic disease? But we also used this to motivate the PURE air study. So could air pollution be partly responsible for this disconnect and a missing risk factor when we're looking at cardiovascular disease? So the PURE air study had 3 main goals. The first one was to add an air pollution exposure assessment to PURE. The second one was to add repeat lung function measurements and then do a comprehensive set of epidemiological analyses, not just at focusing on cardiovascular disease. So the initial challenge was, how do we assess air pollution exposure in 800 communities across 27 countries? And so we approached this using a geospatial approach combined with survey data and then household and personal monitoring data. So could we use these different methods to try to assess different components of air pollution exposure and then ideally put them together? And that's something we're still working on doing. So the first part to look at ambient fine particulate matter we used existing satellite data. So this is the products created by Aaron Van Donkler and Gavin Shattuck that use aerosol optical depth and a number of different methods to take that column and estimate surface concentrations. And so at a global level, those models do fairly well at explaining the existing ground-based monitoring data. So this is the exposure distribution within Pure at baseline. So this is 3-year averages. The mean exposure was around 48 micrograms per cubic meter, and our range went from around 7 micrograms to 140 micrograms. So we are really covering the exposure concentrations that most of the world experiences in terms of outdoor air pollution exposure. And you see we actually had a range of exposure across the low, middle, and high-income countries. And so UAE is a high-income country in Pure, and they had high exposure, mostly driven by dust. So we also looked at other methods and air pollution exposures that we could quantify. And so this is an updated model from the original model we used within Pure, but this was a global daily land use regression model that we created as part of Susan Annenberg's HEI grant, where we wanted to see if we could predict not only annual average NO2 concentrations, but could we capture the seasonal and daily variation in NO2 exposure. And so Andrew Larkin at OSU really led this. This was a massive undertaking in wrangling data. The map there at the top highlights where NO2 monitors exist. And I think it's a pretty sort of stark example of the work that needs to be done in many parts of the world. And so these are monitors that you can access through an API. And so we could routinely update this data. And it's pretty amazing to see how big and large some of those gaps still are geographically in the world. So we collected all of the existing NO2 data we could get, all of the existing geospatial satellite data, and then created a spatial temporal model. And so the time series graphs on the bottom there, that's examples of daily predictions of NO2 for 4 hospitals in 4 different regions of the world. These predictions are at a 50-meter resolution, so I think there's a lot of really interesting applications. This data is available to download by anyone and apply. So if you're interested, please come talk to me. It would be great to see how these could be used and how they compare to other more local prediction data sets. So now we're moving to household and personal air pollution. And so I'd just like to recognize Matt Schupler, who was one of the awardees yesterday. He really led a lot of this monitoring effort. And so we were targeting monitoring PM 2.5 in 2,500 households and for 1,400 individuals at the same time that household air pollution sampling happened. And this was in rural communities, so rural communities in Pure that had at least 10% solid fuel use at baseline. We used John Volkin's UPass monitor to collect filter-based air samples. We measured for 48 hours, and then we focused on measuring PM 2.5 and black carbon using a reflectance method. In addition, 600 individuals wore a silicone wristband, so we heard about passive samplers yesterday, and so those were paired with the UPass sampling. And this map shows where sampling occurred in the Pure study. And so the approach that we used here was really the train the trainer approach. So we were not going to Pure communities to do this sampling and data collection. So we created protocols. We went out and trained the country lead investigators who then trained their additional field staff on how to conduct air pollution monitoring. And so this is just an example from China and India where we were doing that. We set up the UPass monitors in the kitchen, and then individuals wore them on a harness or an armband for 48 hours. And then in the middle there is an example of the passive silicone wristband that was worn. So a quick highlight of some of these results. We ended up getting around 2,500 valid household and 1,250 valid individual measures in 120 countries. It's important to note that when we even look at clean fuel, so gas and electricity, the average for these fuels were all above the WHO target of 35 micrograms per cubic meter, really highlighting the importance of ambient concentrations to household and personal exposures. We saw minor differences overall between male and female personal exposures, but there was a lot of variation between country in terms of the differences in exposure by sex. And the Pure Air measures more than double the available PM2.5 samples that are in the WHO database that were being used for the global burden of disease estimates. And so from this data, we've learned a lot of important information on drivers of household and personal exposure that could be used to inform policy, risk assessments, and interventions. Holy smoly, I see the timer going down already. Okay, so now moving to some of our EPI findings. So these are the exposure response curves that we used in our grant for Pure Air back in 2015. And so these were the integrated concentration curves that used direct smoking and secondhand smoking to inform sort of what that shape looks like at the higher concentration levels. And the red boxes highlight the areas where most of the world is exposed to in terms of PM2.5 concentrations. So Pure Air was really trying to target those moderate to high levels of concentrations in low and middle income countries where there was this important gap in evidence. So here is a summary of outdoor PM2.5. So these are hazard ratios per 10 micrograms per cubic meter. Just focusing on CBD events, we saw a 5% increase in adjusted models. And this was adjusted for everything we could measure. So this is at the individual, household, country level. And then we added in geographical fixed effects. And so controlling for some of these things that are unmeasured. And that made a really big difference for mortality outcomes. And so this is something I really, really want to stress in this session, is that looking at mortality across very different settings and countries with different healthcare services is very challenging. And so if it's possible to look at events, so fatal and non-fatal events, I think that's really important for sort of improving the evidence for air pollution. These are the concentration response curves. Stroke was by far the most strongly associated with outdoor PM2.5 in our models. When we look at household air pollution, so this is just models looking at if you use solid fuels primarily for cooking compared to clean fuels. For CVD events, we see a 14% increase in adjusted models. Again, this is controlling for everything we can measure at the individual level. And then the next model is adding in individual and household socioeconomic factors. And so you see that there's this big attenuation, really highlighting the challenge of separating household air pollution from poverty-related factors. And so there we had education, the percent of income a household spent on food, and then a household wealth index, which was created from household assets. That graph also shows the variation by center that we saw for mortality. And so looking at the different pure centers, how did the association between cooking with solid fuel versus clean fuel vary? This is an interesting analysis that we actually just published with a lung function paper where we had repeat surveys that looked at what households were able to switch from solid fuel to clean fuel during follow-up. So if we compare people who switched from solid to clean to people who consistently use solid fuel, we see this fairly marked reduction in respiratory events, so a 34% reduction. I'm doing math wrong, 24, and a 15% reduction in mortality. And so this was after 9 years of follow-up in this group. And so when we put this together, so this is the Mr. BERT tool that the GBD uses, a meta-regression tool to integrate different studies and evidence. This is for stroke. We see that the results from Pure in terms of household and outdoor air pollution fit the existing evidence fairly well. So you can see that how from 2019 to 2020, this shrinks the confidence intervals for stroke. For ischemic heart disease, household air pollution fits fairly well. but what we observed in PURE is actually much lower than what the existing evidence suggests for ischemic heart disease. So if anybody knows Salim, they know his sort of feelings on the GBD and that whole approach. And so he wanted to see if what we find in PURE using population attributable fractions would match up to the general rankings of modifiable risk factors from the GBD study. And so this graph shows the population attributable fractions for cardiovascular disease events. And so this is one model. So all of these risk factors are in one model to estimate the hazard ratios. And then the prevalence is based off of the prevalence of that exposure factor in PURE. And I think this is really when Salim was convinced that air pollution is very important, when he saw this result in his own data. So household air pollution was actually the third leading risk factor for cardiovascular disease events. And these are the results for mortality. We also have lung function, and so we see fairly strong associations between outdoor air pollution and FEV1 and FVC. We do not see any relationship with the ratio, which was interesting. And we also see those associations paralleled in the household air pollution analysis. This is looking at our measured PM2.5, so where we had personal and household measures for individuals. We also asked about self-reported respiratory symptoms. And so this is where, instead of using a surrogate for PM2.5 exposure, we're actually using measured 48-hour concentrations as our surrogate for long-term, moderate-term, short-term air pollution exposure. And here we see elevated odds ratios for most of our outcomes, with generally larger associations seen for household PM2.5. And so going back to our air pollution exposure assessment, the initial vision was to take these approaches and integrate them so we could have an individual PM2.5 exposure measure for all 160,000 people in PURE. And so we have developed models, so based on our measured data, how much of personal PM2.5 can we predict? And we see that it's around 48%. And so we're now in the process of using these predicted PM2.5 concentrations in our epidemiological analyses. This is challenging because a lot of the things that predict PM2.5 are also related to socioeconomic status or location. And so teasing these apart in terms of can we model it and then put it in an epi paper is going to be challenging. So just to conclude with some sort of thoughts on this collaboration, this is really building off an existing 30-year collaboration. And so PURE Air would not have been possible without the buy-in of all of the local investigators and that trust that it has been built for 20 to 30 years. The local field staff who had no experience in air pollution sampling, no knowledge of environmental health risk factors, were able to effectively collect this air pollution data. And this really spurred a lot of local action and research on air pollution. And so a lot of these centers who before PURE Air air pollution wasn't even on their radar, it's now something that they're thinking about and building local research capacity for. As we know, we knew this study was going to be logistically challenging. I don't think we knew just how challenging it would be. Sometimes it felt like this was a study just of like logistics, of like, can we do it? And then one thing I didn't sort of foresee is just how much data we ended up getting from this study and how long it takes to clean data, to link data, to get data ready for analyses. And so by the time you get to that point, the grant is done and all your postdocs and students have left. And so it's just how do you have grants long enough where you can make it feasible to fully do the analysis that you want to do in the time period that you have. And so I'll leave you with a picture of Mount Hood in Oregon. Put a little plug out, the International Society for Environmental Epidemiology, the North America chapter. We're having a meeting in Corvallis in June. So hopefully I'll see you there. Thank you.
We have time. Question?
We have time for a question or two, if there are any.
Francesco Forastiera, thank you for your presentation. Just a curiosity, in your list of attributable fractions, the various factors, I didn't see outdoor air pollution. Can you explain that?
Is this on? Yes. Yeah, that is a very good comment. And I think that really highlights the challenge of integrating air pollution within traditional analyses frameworks. And so we wanted to be able to run these population attributable fractions at a country and center level, and we did not have the power to include outdoor air pollution at that level. And so in that paper, we have a separate analysis where we summarize the population attributable fraction for air pollution at a global and regional level, but we can't get down to a country level and a sort of regional level with our air pollution data. And that's just variation in power with the data that we have.
Hi, Chad Bailey from EPA. I had a conversation with the U.S. State Department folks with some people in my office, and apparently highly educated potential diplomats have heard the message that air pollution is bad. So apparently embassies across the world have started deploying PM 2.5 and other monitors. You had mentioned the fact that oftentimes you don't have on-the-ground monitors in these high pollution locations. Have you thought about accessing that kind of information? Because one of my concerns is that you said, you have to essentially fit these satellite models in areas where you don't have a lot of on-the-ground data, which means that not only are the high pollution areas high pollution, they're also more uncertain, even with a good global RMSE.
Yep. Yeah, no, for sure. And these models are built like they incorporate the existing monitoring data that's available. But there are uncertainties with satellite-based estimates for sure at a regional local level. And when we first planned PURE, we wanted to actually put out ambient monitors. And Raphael, who is also here, tried to help establish those. So using the air photon monitors that Randall Martin uses in that Spartan project. And it quickly became obvious that it was going to be too logistically challenging to set up outdoor monitors in some of these rural communities. And that's where we switched to really focusing on household and personal. So for sure, there's a massive need. And there's a lot of work to do in that area. I mean, when you look at that NO2 monitoring map, I mean, it's pretty depressing to see where those monitors are not.
Carol Henry, Environmental Health Advisor for Cummins. Wonderful presentation and really data overwhelming just listening to this.
Thank you.
So I was very interested in your approach to the local researchers and investigators and then your activation of the field folks. So there might be really expectations that something would change. So I wonder, I mean, the whole idea recently that we've talked at this conference on research for solutions, not just continued research. And I wondered if there have been actions to take to reduce some of these high pollution areas, and if that happens, how we're going to actually see that did something really result in a better environment.
Yeah, thank you. That's a great question. And I would also highlight that when we did our sampling, we provided like a summary of measurements back to the household and to the individuals that we sampled from. And it was actually really great to see how interested individuals were in knowing their exposure levels and what they mean for health. And so they know that it's not good. And so I think you sort of hit the nail on the head there is what is the solutions and interventions. And that's, yeah, there's a lot going on in that area. We did some work looking at sort of drivers of fuel switching in PURE and what works best in some countries and some communities versus others. But yeah, that's a big area.
Absolutely, thank you. And we'll have time at the end of the session to come back to some of these questions as well. So with that, I will introduce our next speaker, who's going to be joining us online via Zoom. It's my pleasure to introduce Dr. Tiantian Li. Dr. Li is a professor in the Department of Environmental Health Risk Assessment, National Institute of Environmental Health, Chinese Center for Disease Control and Prevention. She has a multidisciplinary background with specific training and expertise in climate change, air pollution, and health. She has conducted several major national-level epidemiological studies and health projection modeling studies based in China. She serves on several national professional committees, including the National Advisory Committee of Environmental and Health Experts and Executive Deputy Director of the China CDC. She also serves as the Deputy Editor-in-Chief of the Journal of Environmental Hygiene. So I will turn it over to Dr. Li for her talk.
Thank you. Can you hear me?
Yes, we can.
Okay. Good morning, everyone. It's my great pleasure to join the HEI annual conference. Today, my topic is clean air policies and related health benefits in China. This is my outline today. First, I will introduce clean air policies in China. Sorry, there is echoes. Can you?
Yes, we can hear you.
Yeah, it's okay. So I will introduce clean air policies in China. Okay, this is a long-term trend of air pollution in China. Actually, this is a study from our group. We use a random forest model to estimate the exposure of PM2.5 concentration in China from 2005 to 2013. Relative to 2005, PM2.5 concentration increased by 2.6 microgram per cubic meter in 2013 average across China. Here, please see this area. This is Beijing, Tianjin, Hebei area with the BTH area. It's a very heavy polluted area. PM concentration increased by 8.75 microgram per cubic meter in BTH in 2013 compared to 2005. The 2013 is a very heavy polluted year. From 1961 to 2013. Actually, the 2013 is the peak pollutant year. Yeah. This figure shows the distribution of Hystad in 2013. In the eastern of the China, we can see that most area experienced very heavy Hystad in this year. Especially BTH area, Beijing, Tianjin, Hebei region, the Hystad reached more than 100 days in that year. So in 2013, the public and the government pay a lot of attention on the heavy pollutant in China. So analyst background, the China issued a lot of air pollution control action plans. The very important one is Air Pollution Prevention and Control Action Plan from 2013 to 2017. After that, there are lots of detailed measures focused on the different sectors here. And in 2018, another very important plan, 3-year action plan issued. Now I will introduce the most important one, Air Pollution Prevention and Control Action Plan from 2013 to 2017. This plan includes 10 main measures, including increased effort of control and reduce emission, and optimize the industrial structure, and accelerate the technology transformation, etc. And the specific goal is very ambitious. By 2017, the urban PM10 concentration shall decrease by 10% compared with 2012. And the annual number of days with very good air quality will gradually increase. And the concentration of PM2.5 shall fall back, especially I just mentioned Beijing, Tianjin, Hebei region, 25%. And Yangtze River Delta is 20% and 15% in Pearl River Delta. And especially for Beijing, the capital of China, fine particulate matter annual concentration shall be controlled below 16 microgram per cubic meter. This is another very important action plan, named the 3-year action plan for winning the Blue Sky Defense battle from 2018 to 2020. Here include 6 main measures. The first one is adjust and optimize the industrial structure. This is quite important. And then adjustment of the energy mix and the transportation structure, etc. The specific goal includes a total emission of SO2 and NO2 decreased by more than 15%. The PM2.5 in non-attainment cities will have been down over 18%, and the cities at or above prefecture level will have recorded clean or fairly clean air during 18% of the days across the year, and the number of the days with heavy or severe pollution will have dropped over 25%. So after all these measures, the air quality improved a lot. This slide shows the PM2.5, PM10, ozone, SO2, NO2, and CO concentration from 2013 to 2020. We can see that besides ozone, all the pollutants decreased a lot, especially for PM2.5. Here is a BTH area. Yeah, Beijing, Tiantian, Hebei. So in 2013, we can see that the concentration of PM2.5 is about 100 microgram per cubic meter. And in 2020, we can see that's about 15% microgram per cubic meter. So the dramatic improvement in air quality in China provides a great opportunity for us to conduct an accountability study. The question is, could the rapid air quality improvement driven by the clean air actions in China bring any beneficial effects on population health? So this is a very important question we need to answer. So next, I will introduce the overview of health benefit studies in China. So because of the time, I can only give a very brief overview. Yeah. So this is the accountability study concept and method. HEI actually proposed this. From the regulation or actions to emission to ambient air quality to exposure or dose or human health response. This is a chain of accountability. In China, these years, there are a lot of studies related to clean air actions. The first, there are two categories, I think. The first category is health risk assessment based method. I will give one example. This study assessed premature deaths from 2013 to 2017. The national annual population weighted PM2.5 concentration decreased from 67 microgram per cubic meter to 45 microgram per cubic meter. And in comparison, premature deaths in 2017 were reduced by 14% due to reduction in long-term exposure to PM2.5. Actually, there are a lot of health risk-based assessment in China. I do not have time to introduce all of this. Here is the main conclusion for this kind of study. From these studies, we can see that China's clean air actions have brought health benefit due to air quality improvement, including reduction in PM2.5 related excess mortality and YLL. And also a study using CMAQ models. This study showed PM2.5 emission controls could contribute 88% to the avoided mortality. And also there are some studies using CMAQ models to see the 4 measures, including strengthening the industrial emission standard, upgrades on some industrial measures, and promoting clean fuels in the residential sectors effectively contribute to health benefit. Another kind of study is epidemiological study-based method study. There are a series study using the CHELS cohort in China. From 2011 to 2015 is a study period, and the health outcome include lung function, depressive symptoms, and etc. The exposure they use a PM2.5 concentration. The method include the DID model, mixed effect models. Yeah, in this kind of studies, they always, here is the 2013 actually. This is before clean air policy, and this is after clean air policy. There is a wave 1, wave 2, and wave 3. So this study showed the PM2.5 reduction has improved the lung function in adults. So based on the mixed effect model, compared with reference in 2011, the mean PEF was elevated by 9 liters per minute and 36 liters per minute in 2013 and 2015. And they found each 10 microgram per cubic meter reduction of PM2.5 was associated with 15 liters per minute improve of PEF. Here's another example. It showed clean air action has improved the depressive symptoms. Based on the DID model, a 10 microgram per cubic meter reduction of PM2.5 concentration was associated with a 4% decreasement in depressive scores. Especially here, it's very interesting. From 2015 versus 2011, they found improved air quality during this period offset the negative impact from the 5 years aging. Through go over all the studies, I think there are some study limitations. The first one is from the control, from the study design. I think special controls are rarely involved. Most are temporal controls. For the outcomes, lack of studies focusing on the mortality as a health outcome. For the study results, most study observed the effects changed, but how contributors for the decline in air pollution related effects could not be fully explained. So then we conduct a study named accountability study in Beijing, Tianjin, Hebei region. This is a very heavy pollutant area. So our study design actually based on a multi-center data set. We use a 2-stage time series analysis. And we consider the time difference and regional difference in the study design. We also we focus on the BTH, this very heavy pollutant area. So for the time differences, we divide the entire study period into 2 sub-periods. One is 2013 to 2015. The other is 2016 to 2018. Then we estimate PM2.5 related health effects separately and observe whether the effects of the 2 sub-periods have changed. The regional difference is this is heavy pollutant area, BTH. We also find another control area, including including Guangdong, Fujian, Southern Hunan, and Southern Jiangxi, which have experienced relatively low PM2.5 concentration, nearly no change during this 2 periods. This is our health outcome and exposure data. We mainly use mortality data from 2013 to 2018, including non-accidental mortality, circulatory disease mortality, respiratory disease mortality. We also using some outpatient visit data in the BTH and Beijing area, and also hospital admission data in Beijing. Yeah, the exposure data include PM2.5 and ozone, and some daily mean temperature and relatively humidity. This is our statistical models, the 2-step analysis. The first one is multi-county time series analysis. The second one is random effect meta-analysis. They also test the difference of the effect from the 2 periods. So this is a preliminary results. We can see clearly the change in the regional PM2.5 concentration from 2013 to 2018. Yeah, you can see that the red color disappeared in 2018. So the mean daily PM2.5 level was reduced by 20 microgram per cubic meter in the period of 2013 to 2018. And the southern area of Hebei here, this part, yeah, indicate a large reduction of PM2.5 concentration. This is our this is the change in PM-related all-cause mortality risk. The red color is 2013 to 2015, and the blue color is 2016 to 2018. They can see clearly there is a decrease of the effect from compared with in 2016 to 2018 compared with 2013 to 2015. Yeah. And the all-cause mortality and circulatory mortality, the differences is significant. Let's see here. This is the mortality effect in control area. We didn't see the difference between these two sub-period. Yeah. So this is the exposure response curve of PM2.5 and mortality at different period in Beijing, Tianjin, Hebei, and surrounding area. Here is the all period from 2013 to 2018. This is the 2013 to 2015, and this is 2016 to 2018. Yeah, we can see clearly here is the linear increase in 2013 and 2015. This is a this is the very little, this is a heavy pollution period. But in the 2016 to 2018, we didn't observe the significant effect. This is the exposure response curve for PM2.5 for the circulatory and respiratory diseases mortality in the BTH area. We found similar results for the total mortality, especially for the cardiovascular mortality. But we didn't observe the linear relationship for the respiratory mortality from 2013 to 2015. So from our study, we can see that there is a significant difference between the two subperiods. So let's review some study very similar with us. There is one study in US. The median PM10 concentration decreased by about 5 to 10 from 1987 to 2003 in US. And they found a weak indication, like the lag 1 effect of PM10 on mortality declined during 1987 to 2000, especially in this part, 1995 to 2000, they observed the smaller effect here, especially in the eastern United States. Another study is Germany study in Erfurt, Germany. Yeah. From the exposure, we can see that from 1991 to 2002, PM2.5 and UFP concentration gradually decreased here. And they also observed the PM2.5 effects decreased. But this is a weak reduction. But UFP showed a significant trend towards the reduction. When we see all these reductions, we want to explain why there are some decline in the effect. So the first reason we think maybe is the influence of changing PM2.5 components. Our clean air actions actually have changed the components and the source of PM2.5. Here is a figure in Beijing, shows the different components. We can see that the sulfate decreased, from 2013 to 2018, but nitrate a little bit increased from 2013 to 2018. So the sulfate it's an indicator of the co-combustion, and nitrate is an indicator of the transportation emissions. So we can see the significant decrease in sulfate and an increasing ratio of nitrate per surface from 2013 to 2018 in Beijing, which means the components in the source of PM2.5 changed. So maybe this is one reason. Another one is during this period, there are lots of actually clean energy usage. Yeah, it's increased. And also the air purifier usage increased. And the wearing mask increased a lot in China. And public attention, especially for the social media, pay a lot of attention on PM2.5. And the government strengthened the highway pollution warning. So all these personal protective actions actually decrease the personal exposure. So maybe this is another reason for the influence of the effect difference. So the last is prospect. Our study actually works on the short-term health benefit of air pollution regulation in China. There is another study leading by Dr. Kinney, from Boston University. We collaborate, support by HEI. It works on the long-term health benefit of air pollution regulation in China. I think this is more important. I heard there is a poster from Dr. Kinney. Maybe you would like to see that. Yeah. Another point is that during our 14th five-year plan, further action actually focus on the ozone and VOCs. Yeah, there are lots of measures focus on these two pollutants. So maybe after five years, we can conduct further accountability studies on ozone and VOCs counteractions. Yeah. This is my last slide. I would like to use this to give my concluding comments. I think for the accountability studies must be based on the interdisciplinary collaboration, especially for the air pollution change. Maybe we should use CMAC models, satellite retrieved data, multi-source data fusion from the atmospheric science, meteorological science, to quantify the air pollution change due to clean air action of different sources. This is quite important. And we also need to multi-dimensions health outcome measurements to integrate the cohort data, big health data, and some socio-economic models. So using this way, we can further improve the accountability studies. So that's all for my talk. Thank you so much. Yeah.
We may have time for one quick question for clarification. If not, we can move on then. Thank you very much. We can move on to then Dr. Laura Rodríguez. Dr. Rodríguez is a professor in the Department of Public Health, the School of Medicine at the Universidad Industrial de Santander in Colombia. She is a physician and earned her PhD in epidemiology credential at the University of Alberta, Canada. Her main research topic is environmental health, conducting epidemiologic studies on the role of environmental exposures, mainly air pollution and heavy metal toxicity, on respiratory, cardiovascular, reproductive health, and cancer. Dr. Rodríguez leads the Global Environmental and Occupational GeoHealth Hub in Colombia. Currently, she is part of the leading team of the research program for environmental health in Colombia, funded by the Ministry of Science and Technology. I'll hand it over, Laura. Thank you.
Thank you. Good morning, everyone. Thank you. So first, I have to say that it's my great pleasure to be here as part of this panel, and also great pleasure to be here in person. I really enjoyed the conference, and I want to thank you, Pallavi, and all the organizing committee for inviting me. I'm going to share with you some of our experience conducting air pollution and health studies in Colombia. We're located in the cold global south, and we are at the top corner of South America. By the way, we are one of the top-rated places for go for tourists, so we're very welcome to have you there sometime. So I'm going to talk on some summary issues that we have in terms of the timeline of conducting this study, the key finding, how we're translating into policy or applications. And also, we're going to reflect on how we transition from local and very national collaboration to international collaboration, and how that helps to shape the things that we have done so far. So this is a very short timeline to try to summarize the experience and the different stages. The first thing that I want to mention is that I think that maybe all things about thinking about air pollution start with measurement. So it was about 1993 when the first air quality surveillance system were placed in Colombia, in the city of Medellin. And that was also the time when the very first local study was addressing the potential effects of air pollution on respiratory outcomes. And later on, as soon as the other quality surveillance systems were also developing, we have the opportunity to start conducting very local city-specific studies. They were related to assessing the short-term effects, mainly mortality, and also some studies related to respiratory symptoms. And then we had a specific break point time that I'm going to talk to you later, when we changed from very local to multi-city studies. We're also, at that time, addressing short-term effects, particularly in morbidity, cardiovascular and respiratory morbidity. But then later on, we also had the opportunity to explore another potential outcomes related to children's health and also mental health with suicide related to air pollution. During the recent years, we've been starting work on long-term exposure assessment of air pollutants and preparing to be ready to assess the long-term effects on health. So all these stages have been transitioning from very local to international collaborations. So some of the key findings that I've been producing for my colleagues and myself, during the first stage, I mentioned like the local studies, city-specific studies, we saw information, particularly for time series study, related the effect of PM10 by that time with mortality, and also there are studies relating children's health respiratory symptoms with the local levels. That first study that you see at the top left corner for you, it was supported by the research group for the SCALA project. SCALA project was funded by HEI, and the participant countries were Mexico, Brazil, and Chile. Colombia wasn't there the first round, but after the study was conducted, the research group from SCALA support Colombian researchers to conduct this type of studies. So those studies provide local evidence. They provide local evidence to inform national air quality standards. In the case of Colombia, we update our regulation and national standard 2010, and then it was updated in 2017. Then we have the opportunity to work together as a national network, and we started working on the short-term effects in different cities, starting in 4 cities, the main cities in Colombia. We also have the opportunity to assess the joint effect of different pollutants. So trying to bring into the picture the multi-pollutant perspective, and that gave the opportunity to highlight to the local decision maker the need to think about the mixture effects of pollutants, and the need to include that perspective into regulation, but also in the risk communication. So we started working on the development of air quality health index, specific for Colombia. We've been working with the Instituto Nacional de Salud Pública de México and the Institute of Environmental Studies in Spain. So we are working also very closely with the government from Bogota, our capital city, because they are very interested in putting this together, growing from local evidence and shaping a risk communicator tool that is more appropriate for our population. And then COVID-19 pandemic came. So as you all know, we have a lot of lessons learned from that pandemic, and we had the unique opportunity for a natural experiment. So we also have the opportunity to assess the changes in air pollution in the Northern South American region. That was a study conducted for some of my colleagues, and they were able to show that the decreasing light, the lockdown, was very useful for the reduction in mobility, and as a consequence, the decreased concentrations in PM10, PM2.5, and NO2. However, that decreasing pattern in the air pollutants were not as we were expecting, that really closing to the WHO guideline levels. We're still higher than that. And part of the explanation was the very high impact that have on that region, the biomass burning for wild forest in the Amazonian region and the Orinoco region from Colombia, that is still like giving us very hard times in the seasonal period in the first months of each year. So it was important to highlight and see with specific evidence that the reduction in vehicle emissions for sure will be a very good help and very good action to shift the lower pollutant levels that we need to achieve. But we also have to work in a control, in a real control of wildfires in the Amazonian region, not only because of the deforestation and the consequences that it has by itself, but also because it's really integrated with the air quality in the region. We also have the opportunity to try to assess in the very early stage of the pandemic how the long-term exposure to PM 2.5 was affecting mortality due to COVID-19. But at that time, we used satellite data to try to define an exposure assessment. But at that time, really, social and geographical inequalities were even higher than the potential effect of air pollution, so we are not able to see a big difference. During the recent years, we've been working on the very first program in environmental health research that have been funded by the Ministry of Health and Technology in Colombia. So yes, only a few years ago, we had the first program funded in Colombia. We have a lot of priorities for research. We have limited resources, so not always environmental health issues are on the top priorities, but it is, we have been working on rising the need for this type of studies as well. So we got funded this program. It has 3 different projects, and one of those is the air quality and urban environmental health in 5 cities in Colombia. So we're still building on the collaboration that we have conducted at the national level, but also expanding to international collaboration, in this case with the McGill Research Group, with Jill, that is right here, and Scott, that they've been supporting us in some of the issues that we have with this analysis. But maybe one thing that I really want to say about this experience is that we have been working very closely with the health and environmental local authorities from the 5 cities. So they are part of the team, and they are being part of the process of selecting the places like analysis, the first findings, this thing, and they have provided very good opportunity to build trust between academic and government, which is, I think, fundamental for the long-term sustainability of these collaborations. One of the things, just a summary of things that we have done in this program, we provide estimation for health benefits of reducing the air pollution levels below the current national standard. We have a national standard, it's currently set up at 25 microgram per cubic meter. And the government has defined in the update 2017 that we're gonna turn to the 15 interim target by 2030. So it's still many years to go. So we're trying to put in numbers how many lives you can save in a very short period, about 35,000. That's just changing a bit faster from 25 to 15, and that was the time of evidence that we provide to the local and national authorities. We have also been working on developing land use regression model using local monitors, outdoor monitors for NO2 and P2.5 in interurban different places of the 5 main cities in Colombia. So we have this this development to try to provide elements for the local government to characterize the spatial variability of the exposures. So local action should be more focused on some specific regions of the cities, but also to provide maybe input for future exposure assessment and the refinement of the exposure assessment that we have available with satellite measures. So I think one of the key points that I want to make here is that if I can say there was a break point transitioning from very local studies to national collaboration related to the funding. We got funding from the GeoHealth program, so we have the GeoHealth Hub Colombia. It was funded between 2015, and it was a great opportunity to identify ourselves within the country as researchers in environmental and occupational health, and start to work together, to plan grants together, and have the collaboration and the experience from people international. In this case, we work together with Leonello Bautista and Jonathan Patz from Wisconsin University, and it really made a big change. So we start keeping those national collaboration, but also expanding our international collaboration. So we're working with University of Alberta on topics related to children's health. We're also working with Mexico, like the government, and also the Instituto Nacional de Salud Pública in air pollution health related effects, and as mentioned, the Air Quality Health Index now. And we also been continuing collaboration with McGill and ICTP from Italy in related to exposure assessment. Worth to mention as well that one of my colleagues, Miriam Gomez from Medellin, has been part of this regional project from ARCAL that is funded by the International Atomic Energy Agency, and it was aiming to characterize the key components of the aerosols of the air pollution mixture, at that time at that specific region in the Valle de Aburrá, where the Medellin city is located. And they had the opportunity to characterize those PM2.5 fractions with a temporal resolution from 2020 to 2022. So they had, because of COVID, the opportunity to assess difference between the pre-pandemic, pandemic, and post-pandemic period. So it's quite valuable information that we have from those research as well. So far, so good, but not that bad. But still, I have to say that we are about 10 years behind you. I mean, North American and European countries in terms not only of health and air pollution research, but also in policy implementation. And definitely, this is a thing that we have to work hard in for the next years and decades to come. So I just want to highlight, thinking from that perspective, of the work that have to be done the next year, what are the main challenges that we have facing so far. And first, I have to mention the data availability. As you mentioned, Perry, there's a very limited air quality network in Latin America. That's true for Colombia as well. Just to mention, in 2019, we made comparison between the air quality network measure that we have with satellite measures, and we only have the opportunity to compare 29 out of 1,022 municipalities in the country. So it imposed some challenges, but also not all those places have open data, so the information is not really available as they should be. So that's an important thing that we have to still working on. The Ministry of Environment is working on a national air quality unified system, but still some issues that have to be improved. The other challenge is the assessment of long-term exposure, different levels related to my previous comment. So we've been working in building intra-urban models, but we have lots of extension in the country that are not covered, but that also still have a lot of work. I have to say as well that there's limited national funding for long-term studies, particularly for funding cohorts. So it is very main limitations because we have conducted cross-sectional time series ecological studies. By transitioning to really population-based cohorts has been a limitation, and we know that robust evidence comes from this information and study designs. So we were changing to apply for different funding internationally, but it's a learning curve that you have to make. So we're in that position. And I have to say that we also have to advance in environmental justice related to air pollution. So we have quite a good research related to other environmental threats in Colombia and environmental justice, and includes the armed conflicts and all the environmental issues that are related to it, but not as much for air pollution, and it's a thing that needs to be covered as well. And of course, as you all, it is a shared challenge. We also have to work on linking air pollution and climate change as part of their research agenda. So those are the challenges, but I'm happy to say that we also have great opportunities. And one of them is that we have local and national authorities able to work with us, working actually with us, and building local evidence that can be translated in policy. So we're trying to close in this like waiting time between the evidence is produced until it's translated into action. We have also been having the opportunity to build in national research capacity through training from national programs, but also in collaboration with international environmental health programs. And of course, we have now quite a higher possibility of applying and be successful in international funding for studies in Latin America and low-income countries. So just to close up this presentation, I want to share some of the next steps that we are working on. So the first thing is we're working on integrating the national data system that we have in place from social, health, and environmental data systems. We have quite a rich data, but they are not integrated. They have to be really it's a lot of work that has to be done, but it's very nice to say that the national government is committed to do that. So we are aiming to create a national census-based cohort for environmental and occupational health analysis, and we are leading this specific work with Carleton University. We'll probably meet. I'm working with right now, and we are really working with different academic institution and government institution in Colombia as well in Canada, trying to learn from the experience from the Can check and all the resources based on administrative data linkages that have been they have conducted so far. So doing very well about that. So we'll also have to keep working on training in advanced methods. It's a really need that was actually identified from the beginning that the GeoHealth program identified needs and opportunities. And that is where also international collaboration play a very significant role. And we also have to work on the evaluation of the feasibility of different scenarios for decreasing our air pollution levels. We have a country with very diverse realities, geographical and infrastructure situations that are very different, so maybe not only one solution fits for all. And as we mentioned yesterday with the conference from David Foster, maybe not only like the electric vehicles is a very straightforward solution for all the diverse situations that we have in Colombia, but we have to evaluate that. And at the same time, we have to promote community engagement, community participation for the local actors to take action on that and help raise the need for individual and community action. And that also touch in turn with the aligning the research agenda with the policymakers' agenda. What are the more important questions to be answered and how can provide those answers in a very reasonable time. And of course, integrated climate change and air pollution research in the years to come. So I'm very committed to keep working on our national network and collaborating with you on international partnerships to aim to closing the gap that we have so far. So thank you very much. And I want to take this opportunity to invite you all to the next ICA conference next year in Chile. So I'm the part, just join the ICA Latin American community supporting the organization. So happy to see you all there. Thank you.
Maybe we can save questions for the end of the session and move on to our next speaker.
Yeah, thanks, Jennifer, and good morning, everyone. So I have the pleasure of introducing our next speaker, who is going to join us virtually, Dr. Kwaku Poku Asante, who is a physician and clinical epidemiologist. He's the director of the Kintampo Health Research Centre under the Ghana Health Services Research and Development Division. Dr. Asante has more than 17 years of experience in health research and has led several studies, such as the Ghana Randomized Air Pollution and Health Study, GRAPS, which he's going to talk about today, which led to several other environmental health studies. He has led numerous research projects as a PI in many African countries, including Ghana, Burkina Faso, Kenya, Guinea, Malawi, and Uganda. And he has been funded from the government of Ghana, Wellcome Trust, USAID, NIH, the Global Alliance for Clean Cookstoves, and the Bill and Melinda Gates Foundation, among others. Today, he's going to talk about his work in Ghana, and the title is Using Evidence for Policy Action on Air Pollution, the Experience from GRAPS Study in Ghana. Dr. Asante.
Thank you very much. So our work has been done by a large group of people, being collaborators from Ghana and also from the US, specifically from Colombia University and other universities that you see outlined here. It's about 15 years of collaboration, and I'll be speaking more about the collaborations and giving our thoughts about that towards the end of this presentation. My goal here is to tell you what we have done in GRAPS and how we have progressed from doing epidemiological research into supporting the government of Ghana and its decisions with data that we have gathered from the field. So our institution is a government of Ghana institution. We are part of the Ghana Health Service. And one usually will ask why the health service is driving an agenda in research for improving household energy. And basically it's based out of the reports that we have generated over time. And our long track record from doing research into policy is guiding us using our core values of excellence, innovation, inclusiveness, and accountability. In Ghana, we put into context our household air pollution, given the fact that about 70% of Ghanaians still use solid fuels and open fires for cooking. And there are several reasons why. I'll go into some of that. But basically, Ghana's policy context has been largely driven by the fact that there is deforestation, there is contribution of household air pollution to climate change, and then its impact on poverty and gender inequality. But until recently, there wasn't much data on household air pollution's impact on health. And so the GRAPS data has provided that data that has supported the policy. So first, I'll talk about some insights from our health studies, and then I'll talk about some insights from our policy-driven studies. Our approach has mainly been along the life course framework, which has been outlined by Leo et al., basically generating evidence right from antenatal period through childhood, and also across the lifetime. We have focused on cardiovascular diseases and respiratory diseases, and we are looking forward to doing other outcomes such as neurodevelopment health. The GRAPS study, Ghana Randomized Air Pollution and Health Study, was a community-level randomized control trial that intervened with an improved cook stove, which is called the BioLite on your lower left, and then also an LPG, which was provided freely to all household members that were randomized into that arm, similar to the BioLite arm. In total, we had about 1,415 pregnant women enrolled. Traditionally, all the pregnant women used 3-stone firewood for cooking. So this was quite a new experience for them. In the process, we also collected a lot of data on personal air pollution exposure, right from enrollment when we identified the pregnant women through about 3 other assessments during pregnancy. And then we did both PM2.5 and then carbon monoxide assessments for both the mothers and then their children. We mentioned earlier on that we provided two interventions, and the control was those that use biomass for. This graph here shows that the expected reductions in PM2.5 was not realized as we would have wished it to be. And so it led to our main outcomes being a null finding if we categorize the data by those that were exposed in the control group versus those that were exposed in the improved biomass group or the LPG. However, there's a lot of exposure response relationships that we have identified and that we think is good to share. And then we will tell you what the next steps are in assessing some of these things in real life. So first is the exposure response relationship between pneumonia and then its effect among gender. All put together, we saw a dose response curve among all children when it came to physician-assessed pneumonia. Those that were exposed to higher doses of CO at a higher risk of physician-assessed pneumonia. But this was more marked among girls than boys in the panel that you see on your right side. This is a slide that shows exposure pneumonia, risk of pneumonia when the mothers were exposed to CO during their pregnancy. And here we see specific times that predict higher risk for pneumonia. In the top right panel, we see that for severe pneumonia, and the participants were at higher risk if their mothers were exposed to higher concentrations of CO, carbon monoxide, during the latter part of their pregnancy. And then the lower panel is that for pneumonia, and then we also see that around 32 to 36 weeks, children were at higher risk. This is a panel that also shows the impact of low birth weight. In all, we see again a dose response among children that received that were exposed to CO. They were exposed to lower birth weights with increased carbon dioxide, especially when we had a lot of data. And so if we looked at that, we categorized those that have malaria and those that did not have malaria, because in our area, the prevalence of placental malaria is very high. And so it was evident that the exposure, dose response exposure was very marked among those that did not have placental malaria. And we conclude that in places where placental malaria exists, the impact of carbon monoxide on low birth weight will be masked. This slide shows our assessments on respiratory outcome. We noted that elevated carbon monoxide exposure was associated with higher respiratory rate, and also elevated carbon monoxide exposure was associated with impaired lung function. So the panel you see in the right upper side is that for the lung function, and that for the lower panel is that for the respiratory rate. So we followed up our participants over time. We've looked at the control group and then the cook stove group to see how well they have impaired, and we have assessed CO monitoring and PM 2.5 monitoring over time. And we have various outcomes, some of which I'll share in the next few slides. One is looking at the household air pollution exposures with growth. And we note that prenatal household air pollution to carbon monoxide and actually to PM 2.5 increase the risk of lower length for age and stunting. And postnatally, children were at risk of a smaller head circumferences, smaller mid-upper arm circumference, and lower weight for length z-scores. Next, here we see the association of household air pollution with higher blood pressure among children aged 4 years. We identify that between the months of weeks of 35 to 40 weeks of gestation, when they were exposed to higher risk of high blood pressure among children that were aged at 4 years of age. The other panels you see here are categorized into those that use an LPG. And we note that at age 4, diastolic blood pressure Z scores were lower among children that were born to those that used LPG. Here we looked at household air pollution exposure with impaired lung function, and the trend is similar. The risk of impaired lung function among those that were exposed to higher doses of carbon monoxide between 35 to 40 weeks of age, gestational age was quite high. So what are the key takeaways? We've shown that there is evidence of impact of household air pollution on lung function, growth, and blood pressure. We're doing analysis on effects of nasal and gut microbiome, but there are some trends over there. We are also working on distributed lab models that seeks to assess the impact of concentrations on mid to late pregnancy or various other outcomes. Now, in the next few slides, we'll be talking about how these have informed policy decisions and also have gingered up our policy discussions at the national level. Ghana decided to ramp up the use of improved cook stoves and improved fuels. So the government decided to distribute LPG in rural areas. At the time, only few people, less than 20% of people had used LPG in the communities where we worked. And we note that although the government distributed free fuels and also free stoves, there was an issue of barriers. And some of these barriers were cost in terms of transportations and cost in terms of some of the logistics that are required for using these stoves. And distance was also a factor. So we sought to evaluate this in a randomized variation, price and distance to cylinder model. And here our suspicions were confirmed. Usage was better if they were able to afford giving lower prices of LPG. And then also usage was improved if the source of the LPG was closer to the households. We also did other studies that looked at improving use by home delivery of LPG and also adding health education to it, with the assumption that if people know the health benefit of using improved stoves and improved household energy fuels, they would seek to use these interventions. However, we noted that although there was evidence of improved knowledge and attitudes with educational interventions, there was still no evidence of meaningful changes to sustained use. And so there was still that barrier of distance and also cost. We are now working on Colombia World projects. This is a new effort in Ghana. We've done a national survey to look at household energy use, and that has also informed the national decision, and the data is available for the country to use. We are looking at behavioral change. We are looking at how to transition people from various forms of clean energies, because we think that it's quite steep to move from biomass fuel to LPG. And if there are others that could help, we want to look at that. I mentioned earlier on that in our interventions in graphs, we realized that those that use LPG do not have significant reductions in household air pollution. And this was because we randomized at the individual level. Now we are thinking about doing entire community transitions to ensure that they all use clean fuels to minimize the risk of the next household's biomass fuel getting contaminated in the next one that is using a cleaner fuel. And we are working with our government to partner to ensure that we look at the best ways to overcome the barrier of financing and the barrier of accessibility to cleaner fuels. So putting all these together, what do we want to do and how do we move forward? We think we have been able to answer some of the questions, but there are still a lot of questions to be answered. We've been able to identify the problem. We've done and its impact on health. We've looked at some of the mechanistic pathways. We've also looked at in our cohort study and how people can feasibly transition to cleaner fuels. And we are still looking at tools and how that becomes representative of the national agenda. But there's still a need to assess the impact of all these interventions that are being put in and how it changes, improves health, and how it's sustainable, and then how this changes behavior. What have we learned over time? I mentioned the health benefit and also how we have progressed with the national partners. But I specifically want to focus on our collaborations with our key partners from Colombia University and other universities in the US, and also from collaborating with partners within Ghana and elsewhere. The partnership has led to a widened environmental health platform that has grown over many years now, 15 years and over. We've been able to attract several research grants through these collaborations, and that has worked very well. We've built human resources. We're doing a lot of assessments in our area, and I can say that the air pollution assessment that we have done in Ghana seems to be the largest of all. We have been able to build capacity, long-term studies, though not as much as we have, and just because of the lack of opportunities. But in the last few years, we seem to have made some progress in that direction, but we still need to do a lot to build capacity of many people to sustain the research agenda that we have. And that's where we have to go from here, to build capacity, to follow up this cohort beyond the 15 years that we have done, to assess impact of household air pollution on a larger population and also into adulthood. I'd like to thank you and acknowledge all those that are listed here, and also acknowledge the organizers of this meeting. Thank you all very much.
Thank you, Dr. Asante, for that excellent presentation. I think if there is a very quick question, we can accommodate one question. Yeah, if not, maybe we'll go to our last speaker of the day, Dr. Josh Rosenthal. Dr. Rosenthal is a senior scientist at the Fogarty International Center of the U.S. National Institute of Health. He's an ecologist with a long-standing interest in the integration of public health, environment, and international development. Dr. Rosenthal completed his PhD and postdoctoral research at the University of California at Berkeley. He has developed and led numerous programs at the NIH in environment and health research and capacity building in low and middle income countries, including the Global Environmental and Occupational Health, GeoHealth research hubs, the Household Air Pollution Intervention Network, and the Clean Cooking Implementation Science Network, and he currently co-chairs the NIH Working Group on Climate Change and Health. Today's talk will be titled Building Equitable and Effective Research Partnership with LMIC Scientists in Environmental Health.
Good morning. Thank you very much, and for staying to the end of this. This is the first time I've been to an HEI meeting, and I hope after this talk I'll get invited back again. It's an unusual talk for me, and I'm taking the liberty to make some personal reflections as part of it. And I noticed this morning that the disclaimer in the right-hand corner is missing a key word. They do not represent official views of the NIH in the U.S., especially the last part, the advice. That's really my take on things. So I'm going to start with a little story about a medical research institution in Peru, and then how we took those lessons and a broader view of things to apply to our own sort of program development, thinking about institutions. And then I'm going to end up with this sort of personal reflections of where I think particularly high-income researchers need to think about how they approach global health research. So starting out, I'd like to talk a little bit about the history of the Universidad Peruana Cayetano Heredia in Lima, Peru. That is, when I first visited in the mid-1990s, was a small medical school focused on teaching, very little research. There was a couple of infectious disease projects there. A good place, but a very modest research program. They had 1 or 2 NIH grants. That was why I was there. We began to notice latter part of the 90s and in the 2000s, Peru and particularly Cayetano showing up again and again in research projects as under subcontracts initially and then becoming eligible and capable grantees themselves, not only at Fogarty, my institution, FIC, the orange one, but also at many other parts of the NIH and other institutions, including the Wellcome Trust and the Gates Foundation. And so, you know, how did they do that? It was sort of something that struck us as our mission at Fogarty being one to help enable global health research around the world. Why was this institution stepping up so relatively quickly? But that picture of funding, as you might expect, paralleled by a really rapid increase in scientific publications that cite Peruvian institutions. Most of those are from Cayetano and over this 15-year, 20-year period. When you look, if you do a Web of Science analysis of all those papers, you find what you would expect is a very heavy focus on infectious diseases, diarrheal disease being a major emphasis, as well as tropical medicine, parasitology, and others. But look where environmental occupational health sits. Now, much of that, there was indoor air pollution work, it was high altitude research people were interested in, and then some of that being water quality related diarrhea. But still, quite impressive for this little medical school. So then we began to think, well, so that's got to be partly about the collaborations. And so we looked at, did bibliometric analysis, some colleagues of ours at the National Library of Medicine, Alicia Levinsky and her colleagues, and we saw that Cayetano, if you look at this list of institutions on the left, was in fact collaborating not just with the regular suspects in the US, Johns Hopkins University, and a number of Peruvian collaborators, but with others from several different countries around the world. And, and if you look at that at a country level, authorship networks, you'll see that to be expected, the US was the largest source of collaborators, but there were 25 other countries involved there, and notably England, and with funding from the UK, and Brazil, and Spain, all over the world. So we thought this was a really interesting basis for a model. And I'll come back to some of the details of that in a minute, but we were in the process of thinking about how you build centers of excellence around the world. And we looked at Cayetano, and we looked at Makere in Uganda, Natal, Moi in Kenya, Natal and others in South Africa, half a dozen other institutions that had grown rapidly and developed real capacity. Most of that was in the infectious disease space, of course, AIDS and other non-infectious diseases. And of course, one of the things that we did, this sort of series of case studies, concluded was that multiple international collaborations and multiple funding streams were key levers for that. But of course, as well as a critical mass of scientists, international recognition, support by the national governments, commitment from their institution to grow international research, and then competent administration, which is often a challenge for historical and funding reasons. So I'm going to now turn back and look at what we did to look at our lessons about our own, at that time, or still signature environmental health program at Fogarty, which was the International Training of Environmental and Occupational Health, which had been going on for since the mid-90s, started by my mentor, Ken Bridboard, and my colleague, Joel Bremen, to do research on a wide range of health concerns related to environmental occupational health. This is the final cohort that represented 2006, 2011. They're relatively small grants, $165,000 a year in 2011, spread out among 16 institutions They're working with many other countries around the world, each of them, again, on a diversity of areas. When you go back and you look at the history of the program, they were reasonably productive for small grants, looking at a wide range of environmental health sciences. They generated some high-impact publications and some impacts on policy, which we were gratified to see in a wide range of areas. In addition, there was training, which was an important part of their mission. But if you'll notice, and I don't know if this pointer doesn't work, it doesn't translate over there, does it? No. It's mostly short-term training, workshops, certificate training, and some sort of collaborative work, and a little bit of masters, a few PhDs, and rarely a postdoc or two. The striking thing was when you look at their institutional collaborators. Now, this is all the institutions we could find in their databases over the 15-year period of history. So there's a lot of them. So just in Latin America, on the left there, Eastern Europe on the right, Asia on the left, and then Africa. There were over 100 institutions involved through this model of through one grant to a U.S. institution that chooses collaborators in several parts of the world to do research and training with. The challenge to me, when I went back and looked at this, myself and my colleagues, is that in all this list, I couldn't find a powerhouse environmental and occupational health research institution, a go-to place in the developing world. There's a lot of good people, and don't get me wrong. I mean, you know a lot of the talent in all of these countries. But a strong institution that would be a centerpiece that would attract researchers from around the world, where you could do global standard development and regional outreach, we just didn't see it. And so we go back to this concept that I mentioned earlier about centers of excellence. How do we get there? So I'm going to turn back now to, oh, no, I'm not. I'm going to talk about that. That was the transition point for us to move from this model of one grant to a U.S. institution that then collaborated with others. The U.S. institution tends to drive the research and is, really in control of all aspects of that. What we did was try to turn it on its head and offer two separate grants, where the research grant goes to the low and LMIC institution. They pick collaborators, and the training grant goes to the U.S. institution. These are bigger grants, but not huge. Together, it's $600,000 a year for 5 years, which puts the leadership role for picking topics, identifying trainees, working with policy institutions, developing curricula. Well, that's more of a collaborative. It's all collaborative. These are submitted together. They have to be written together. They're reviewed together and then awarded together. Administratively, it's complicated. I will definitely admit that. And then they're funded as cooperative agreements. So I don't have time to go through all the history, but this is the most recent network. I'm very pleased to hear Laura's acknowledgement of the Colombia hub from the last round. The current projects now, we are 7. One remaining in Latin America, guess which institution, in Peru, as well as several in the Middle East, Mongolia, East Africa, directed by my colleague here on the Quiros, India, Bangladesh. Most of them have air pollution components, and several have climate change, which we see as an important way to go. So we think this is a promising avenue, but I will freely admit it is still a model in development. I don't think we know for sure it's the right thing to do in many respects, whether it proves to create institutional powerhouses that are global go-to centers for research, I think we will still see. But we're pretty pleased we're in the right direction. So let's return to this lessons around Cayetano for a second. And this is where I'm going to come back. You remember that description I had of the co-author, the Institutional Research Network. Let me go back. So if you drill down on that network, what you find is that by individual authors, you find that this one person had this huge impact. Bob Gilman from Johns Hopkins spent about 6 months. He got all his teaching done in one semester and spent 6 months a year in Lima and collaborated with everybody. And he mentored many, many students at Cayetano and the surrounding institutions. So people you might know, Will Checkley, Jaime Miranda, Hector Garcia. These people are now world-class researchers, some environmental health, they're in infectious diseases, they're many places. So I like to call this section Lessons from Bob. And I checked with Bob by email. He said, I got a message back this morning. He said, that's okay. And they're really interpreted by me, a reflection of my experience looking at these projects over my career in environmental at Fogarty in global health. So here's a little bit didactic. These are not a systematic set of recommendations, but I hope there'll be some nuggets here that might be useful. Some of them are a little preachy. Just ignore them if you don't like them. But here's some context that not everybody's clear on. So first of all, in low and middle income countries, grantsmanship and scientific writing skills are very limited. Even very sophisticated scientists do not have experience or know how to write the type of grants that we do. So, and when they do, it's just the elite faculty. It's the people like KP and Laura and others, Kalpana Balakrishna, who couldn't make it today. But just under the surface there's a huge pool of really passionate, smart people that you just don't interact much as a senior international researcher with grad students. So keep your eyes out when you're working with these young folks, because several of these people are now going off into graduate school and elsewhere, and learned a lot from, this was actually out of the Happen trial, but so to look for junior faculty, because the senior people are stretched really thin. If they're working with you, they are the tip of the iceberg. That means they also have major administrative responsibilities and have enormous, a big workload. So keep your eye out for junior researchers. The indirect costs that we pay, at least the U.S. government, are definitely not enough. It's at 8%. We are pleased to be able to do that. But it doesn't cover the real costs locally. So think about how to cover those costs directly if you have the latitude to do that. Similarly, their research administration offices tend to have very modest capacity. It's not unrelated to these features I mentioned up above. They're underfunded and in many ways. So that kind of direct support to even research administration has big payoffs. So let's talk also about how you identify a research question. The history of global health research or international health research was kind of a colonialist enterprise. Go where the diseases are, find them, study them, bring the lessons back home. Well, really, that's not the way we want to be operating today. It's the wrong way to do it, and it won't help them or us in the long run. So think of your collaborating institutions as sites, which was the old way, and it's a language I'm afraid my institution has been guilty of fomenting, is not only pejorative, but it provides tunnel vision. It has you thinking about this one narrow topic on site, which then tends to obscure opportunities for discovering impact in other areas. So think about engaging your collaborators at the outset. This is obvious. Everybody says they do it, but it's remarkable how actually little that's done. You bring your overseas collaborator when you think you know how you're going to get the money, you know what the questions are. talk to them at the beginning, because they'll have real responsibilities, including whether the findings will be implementable locally, and whether the project will yield valuable skills to your collaborators. Be prepared that at least their bosses, their policymakers, may want you to replicate a study that's been done elsewhere and already pretty accepted, because they'll need that locally developed evidence to drive policy in their own country. So if there are ways that you can do that, just be prepared for those requests. And then we've heard something about report back today. That is critical at multiple levels, the community levels, the institutions that people are working in, and the policymakers. It's time consuming, but it's critical to long, sustained relationships, as well as making impact. At Fogarty, we feel that doing explicit, focused research capacity building is an ethical imperative when you're working in low and middle income countries. And I'm not really counting the occasional guest lectures that most of us do, which are not to say they're not valuable, but real capacity building involves sustained, targeted efforts. The training grants, such as my institution and some others that NIH offer, may be the gold standard, but there are lots of ways to do it, right? You can help them find fellowships from your institution, from HEI, from NIH, from the EU. There's lots of opportunities out there, especially today. So there may be ways to, get them on online courses at your institution in the US, and convince your institution to waive the fees. Think about individually mentoring these students. Everybody has a lot of students. Often it's a very time-consuming activity. But think of the mileage and the impact you could get out of bringing up a new PhD student at another institution, a low and middle income country, who represents the real future of that institution in that country. Reciprocal IRBs, grants administration workshops, which are actually kind of interesting. The grants folks in your institution would be delighted to work with partners overseas. Bring them over there and back. And to work together. It will both improve your project and the administration of it, getting all those contracts done, but it'll make that institution better. And leverage your students, the postdocs and staff. They will build lifelong relationships, new careers. Also is a very effective use of that time. This photo is of Bonnie Young, a person that works with Jen and Maggie Clark at Colorado State with a small amount of money, leveraging some existing Happen data and the links to another project that I run. We were able to bring these, Alfonso and Patrick, up to they're approaching their PhDs now with a relatively modest investment in a couple of years. Little to the institution, support for Bonnie, who does very hands-on work. I think it's a really interesting, powerful model. It doesn't take a huge effort to make a big impact. And probably well over time. All right, so I'm not going to say much about authorship, except to say it's a very complicated field. The models that we are used to working with are not defined for high-income, low-income relationships, and we need to rethink those and think it through carefully. My main message is, in the end, it's all about the people, right? Yes, of course, it's about the science, but the science doesn't happen unless you invest in the people and you build relationships with them. And the sustained collaborations over decades, two of my favorite people in the world here, yield enormous, enormous impact. And it does require a commitment on both sides, but often it's very worth it. Stop there and apologize for going on so long.
Thank you very much, Josh. Josh is too modest to say it, but actually a lot of the success at Fogarty is due to his dedication and many others at Fogarty, as HEI is actually now have been doing for a while and expanding its horizons as well. So we have a little bit of time for discussion. If you have any questions or any comments to make on this session, would love to hear from you. Until someone is, there you go, okay. Great.
Yeah, John Wall from Cummins a long, long time ago. Just an observation and then a question. The observation, and this was just brought to mind by one of the presentations this morning, but I'm not interested in calling anybody in particular out. But if you're 90%, if your 95% confidence intervals overlap by 90%, you don't actually have a statistically significant difference. You might need to get a bigger n, so the square root of n in your confidence interval denominator gives you a tighter range. You may have a trend, but honestly, I think talking about some of these as definitive differences really undermines the credibility of the definitive differences that we do see. And so this, again, I'm not trying to call it, this may actually be a comment more for the review committees than for the representatives, but I couldn't resist making the comment. The question is, and Perry, you brought this out, and I was sort of curious about it. How do you take into account the difference in critical medical care in some of these countries as you're making the distinction between incidence of events, which is probably a little more straightforward, and then mortality that's associated with them? So I'm sure it's an issue, and since you brought it up, I'm kind of curious about how you deal with that.
Yeah, no, that's a great question, and something that we spent a lot of time thinking about in PURE. And so the benefits of PURE is you capture these really diverse populations and communities. But what can you control for with measured variables versus what you can control for using sort of geographical fixed effects? And so for household air pollution, that's a lot easier because we put in community and regional indicator variables. So we're only comparing people in that same region or in that same village. For air pollution, for ambient air pollution, is more challenging, because as you include smaller geographical fixed effects, you're explaining away that exposure variation that you're interested in. And so it's this balance between controlling for potentially unmeasured factors like healthcare and still having exposure variation to examine. And so there we used center fixed effects, which had a huge impact on mortality-related estimates. And so incidence didn't change as much. Mortality estimates actually got a lot bigger as we further controlled for potential geographical confounding. But yeah, that was something that with the PURE study design was like a benefit and a challenge of how do you balance that?
Hi, Rami Al-Furra from Qatar Environment and Energy Research Institute. So I have a comment. I've been thinking about this for quite a while, and I couldn't think of a better session to make this comment than the global session. And it's really related to the ongoing discussion on PM mass versus differential toxicity that was highlighted a few times in terms of the health effect. And here's the comment I'd like to make. It's the differential toxicity of PM mixtures rather than individual PM components. If you think about it, hardly any one of us globally breathes in ammonium sulfate alone, or black carbon alone, or nitrate alone. We always breathe in mixtures of pollutants that are dependent on interactions of different sources. And in a global session, when you think globally, if you look from satellite, we will maybe identify fewer very specific mixtures globally. There will be regions where we have a lot of anthropogenic with biogenic, like in Europe, Northern America. You will have natural dust with anthropogenic in arid regions. You will have marine environments. So there might be somewhere in between answer to this toxicity versus mass, which is the mass of different characteristic mixtures. So that will call for response factors, concentration response factors developed for different regions rather than for different individual components or for, and this will have another layer of spatial and temporal variability. So seasonally in Europe, you probably have more wood burning and adding to the mix. and then the indoor and outdoor will be a different story. But this is, I think, where we need probably to have more discussion in Africa, in the Middle East, in Europe, and that's kind of response factors on a total PM mass, but specific to regions, I think is where my kind of thinking is, and I hope I have some comments back on this. Thank you.
Yeah, thank you for that comment. Any reflections?
Yes, thank you for the common question. And actually, I have to say that in the case of Colombia, this work that we have conducted in 5 cities, taking only intra-urban variability, that show us that when comparing PM2.5 concentrations against oxidative potential that we were allowed to do it with crystal polyp, we have found that they are not related. So the places within the city that had the highest mass are not necessarily the ones that have the higher oxidative potential and potential health effects. So we're starting to think about it and see maybe if the intra-urban variation of that alternative measure will be guided a bit more on how to address not only the local intervention, but also the risk communication to communities, because it would be even harder to explain to the people. So just starting to move, but sure, it's part of the things that we have to work on that.
Thank you. I don't know, not to put you on the spot, but Perry, since you have done the global work, if you have any reflections on this question specifically.
Yeah, no, that's a great question. And I think something that we want to work towards. In Pure, I think it was challenging enough just to look at PM mass, but that is the direction that I think we need to go in. And we do have the PM filters we collected, and so we were thinking about doing composition, and we have the wristbands to look at other chemical mixtures, but it's just finding money to do all that analyses, and so that was all add-on in the grant. So we weren't funded to do that, but if we're out in the field, right, we wanted to try to collect as much stuff we could use in the future. But yeah, I agree that's an important future step.
Yeah, thank you. Dr. Li or Dr. Asante, if you have anything to add, please chime in at any point.
Hi, this is Pat Kinney. I'm from Boston University. I have a question for my colleague up there on the screen, KP Asante. I really enjoyed listening to your talk, but I was wondering, now that you've built the world-class capacity in environmental health at Kintampo, whether there's been interest and opportunities and also maybe efforts to start to spread capacity to other sub-Saharan African countries. Is that a project that's been started yet? Thanks.
Dr. Asante, I think the question is to you, and then we'll move to the other panelists.
Yes, thank you, and good to see you, Professor Kenny. And we started all this. Yes, we are thinking about that. We actually just submitted a grant. Part of it was to begin to think about looking at collaborating with other West African countries and to build up that capacity in there. But you're right, there's that huge potential to do multi-country studies, as we have done on our malaria model. It's currently running. So we're looking forward to opportunities to do. Thank you.
Yeah, thanks.
Hi, this is Matt Schupler. My question, I think, is mostly for Josh, but anyone on the panel. So, Josh, your presentation really resonated with me in terms of working in low middle income countries, and you see a lot of junior researchers that are very interested in developing their capacity, but they lack the training. And so sometimes I find myself trying to locate different online resources for them to give them training, because as researchers and postdocs ourselves, we often don't have the time to help. We try to mentor them as much as possible. So I was wondering if NIH or HEI has thought about other kind of smaller fellowships or funding for targeted courses that can be done online, because a lot of times we focus on fellowships or PhDs, but the problem I find in a lot of low middle income countries is that they may not have the ability to travel for a PhD, and they want very specific training. And so I know some universities in high income countries may offer courses in R or writing programs, but if there's more targeted, low-cost kind of grants or opportunities that we can use to provide this certain training in writing or coding that may not be a full PhD, but targeted skills that they desperately want, but we may not have the time ourselves to provide?
Yeah, thanks for that question. I think it should be on.
Can you hear me? No. Oh,
Yeah.
sorry. Yeah, it's a good question, and you know, this is something that my former boss, Roger Glass, was very big on, which is how to, if we can't get to scale without distance learning measures. So we've been playing with this for a number of years, and I don't think we have the perfect model. Typically now, in some of our training programs, there will be online modules developed for use regionally. They have to be, depending on the subject matter, have to be contextually relevant, and they have to obviously be in an appropriate language. So there are some, but to the extent they're in English, you know, I think building catalogs of these is important. And other than the, you know, the sort of things we know about Coursera and these others, I don't know of any institution that hosts them systematically. But certainly I think it's very relevant. I don't know if there may be happening in the DSI Africa. We have a new Data Science for Africa initiative that Cardi Wright is involved in, and there may be some work going in that space too to enable online skill development and ultimately degree training too. I think you need to build careers. They need not only to use R, but they need to understand how to ask questions and analyze data.
Yeah, go ahead.
Yeah, maybe just to add there, I mean, so one thing that we found is there was a lot of interest in sort of geospatial methods, but no training, right? No licenses for ArcGIS. And so we put together a 2-day workshop using the Google Earth Engine. And so the Google Earth Engine is free. You can run it on a laptop and do planetary scale analyses that were unheard of before you had access to that resource. And that has been extremely valuable in terms of giving local investigators access to satellite imagery from 1980, right? To do local level analyses to support policies or projects or grants. And so I think even those like short technical sort of trainings can have a really big impact if they're accessible to people who
yeah, thank you. Maybe I'll make a couple of comments before we go on to Mike for the last question. Other comments? Please go ahead. Yeah.
Yes, that's a comment. I mean, thanks to Matt. And I just want to say that in the collaborations, we should make time. And the PI, those collaborations should make an intentional effort to build capacity. And Matt Maynard lived up to that in collaborating with some of our research fellows to write papers. I congratulate you for that. All the online courses are there's no such joy as having collected your data with collaborators like Matt and having written it up as a test for that, using all the resources available like licenses to be able to get to that level. That for me is a huge impact that anyone can make. Beyond just writing the papers, it builds collaborations. I'm sure somebody like Matt can just take the phone and call any of our research fellows in Ghana to say, hey, we have this grant, can we lead it? Can you lead it? And that's what we're looking for.
Yeah, thank you. Maybe Mike, go ahead, please.
Hi, Mike Jarrett from UCLA. Really great panel. Thanks to everyone for the fantastic presentations. I have a question about the policy relevance of this work. And you often hear, and we heard it yesterday a few times, we already know PM 2.5 is bad, and I totally agree with that. But what's the importance of having locally generated results that show it affects health in these particular populations? Because I often hear that, and I really like your reflections. People in places that are very polluted and say, well, I don't want to take results from Europe and America. I don't trust those. So I just wanted to see how important it was from your perspective that these results are generated locally for formulating policies.
Yeah, thanks, Mike. Any reflections?
Yes, maybe to say that international evidence, it's out there and it has shaped the local decisions in terms of pollution. So the very large cohorts that are available, but adding local perspective is helping the local authorities to act locally. So, you know, air pollution is bad, PM2.5 is bad, it has different adverse effects, but where you have to prioritize your actions, where is it happening? So that's the aggregate value of having like local studies, but also the way how you approach the message to the community. So it's not happening there, far from here. It is really happening here. And it's the way how you can also empower like, local activists and local communities to work and to think that even though you can see it, Earth and climate change is there, and we have to take action right now. I think that maybe it's the word valid.
Yeah, thank you. We are almost running out of time. If you have a quick comment or a question, please
Well,
go ahead.
I wanted to thank Dr. Li for her tremendous presentation on the impressive progress that China has made. And it occurred to me that we haven't heard anything about training or how you have been able to get the experts that you need in China, and whether you are providing any training outside of China or some of the challenges that we have, since you now have quite a pool of expertise. Thank you.
Thank you. Dr. Li, the question is for you. I don't know whether you heard it. It's about training in China and outside of China.
Okay, I hear. Yeah. So I think here in China, we have lots of training for the scientific research. So the researcher like me, actually, I was training in the Columbia University for my postdoc degree with Dr. Kinney. So I can do a lot of research for the air pollution and the health. And also for the air pollution and health, we learned a lot. Can you hear me?
Yeah, go ahead.
Yeah. The air pollution and health, we learned we studied a lot from the the overseas scientists. Yeah, we have a lot of the international conference for training the methodology and so on. Also, we can send our colleague to U.S. University, like our colleague Pant. She is in the conference room. Yeah, she is now working in the Yale University, working with Kai. Yeah, so I think we have a lot of trainings. Yeah.
All right, yeah, thank you very much. This has been a very engaging session. Please join me in thanking all our speakers, both online and in person.